When we talk about doing diagnosis, there are 5 axes that we want to consider. The first axis is your mood and addictive disorders and some of your developmental issues. The second axis includes more of your developmental issues and the personality disorders. The third axis includes medical issues. The fourth is psychosocial, and that includes everything from relationships to employment to finances to legal issues and housing. And the fifth axis is the global assessment of functioning. This is a general idea on a scale of 1 to 10 of how a person is functioning. 1 being they need to be in the crisis stabilization unit, they are a danger to themselves and others, and maybe pretty much comatose, to 100 being that they are functioning just fine and have no symptoms at all. The first thing we're going to talk about is attention deficit hyperactivity disorder. When we look at people with potential for attention deficit hyperactivity disorder or just attention deficit disorder, we need to consider the following symptoms. They need to have 6 or more of the following symptoms for at least 6 months to a degree that is maladaptive and inconsistent with developmental level. And those 2 things are very crucial in the diagnosis. It has to be causing problems, and it has to be inconsistent with developmental level. 4, 5, 6-year-old boys are going to be rambunctious, but is it more so than you would expect given that child's age, culture, gender, etc.? Children with ADD or ADHD often fail to give close attention to details or make careless mistakes. They often have difficulty sustaining attention in tasks or play activities. They often do not seem to listen to when spoken to directly. They often do not follow through on instructions and fail to finish schoolwork, chores, or duties in the workplace. Now, one of the things when we talk about people with ADD, ADHD, either adults or children, it's important for them to have lists, and especially with children, you want to give them simple directions. Don't tell them, I want you to go into your room, clean it up, mop the floor, do the windows, and make your bed. That won't get done. They'll get to their room and start looking around. They may remember one of the things that you said. So you need to make it very clear. You can post a list in their room of the different chores they have to do every day, but make it simple. They often have difficulty organizing tasks and activities. In order to organize, you have to remember them all, and people with ADD, ADHD are just too distracted. They often avoid, dislike, or are reluctant to engage in tasks that require sustained mental effort, such as schoolwork or homework. This is really challenging. One of my peers who had ADHD gave us an example one time. We were trying to do presentations, and she was standing up there doing a presentation, and we were all trying to focus. And she started flicking the lights on and off, and then she had somebody else start making a bunch of noise in the background, and somebody else started making some other noise in the background. She said, this is how it is for me every day, because all stimuli have the same amount of importance, or they attract the same amount of attention. So it's really hard and energy consuming to stay focused on one thing for an extended period of time. Adults or children with ADD, ADHD do much better when they have to focus for long periods of time if they can be in a quiet place where they're not distracted by other visual or auditory stimuli. They often lose things necessary for tasks or activities. It's often easily distracted by extraneous stimuli. We just talked about that. And they may seem forgetful in daily activities. Well, if you've got 18 things catching your attention, it's going to be hard to remember everything. If we're going to give them the additional hyperactivity diagnosis, some of the following symptoms have to be present for at least 6 months, and again, be inconsistent with developmental level. This includes fidgeting with hands or feet or squirming in their seat. leaving their seat in the classroom or in the car or in other situations which remaining seated is expected, such as at the dinner table, especially at a restaurant. Often runs about or climbs excessively in situations in which it's inappropriate. In adolescents or adults, the person may have a feeling of restlessness. They often have difficulty playing or engaging in leisure activities quietly. When these people are on, they are on and wide open. These people are often more on the go or act if they're driven by a motor. You know, all of us remember the little Energizer bunny. And they often talk excessively. Their minds are going a million miles a minute. That hyperactivity, it's kind of like the average person if they've had way too much coffee or they took a whole bunch of decongestants before they came to work. The impulsivity is one of the things that often causes challenges in differential diagnosis and also in treatment, especially if the person has a corresponding substance abuse disorder. Impulsivity is a characteristic of substance abuse, but it's also a characteristic of ADHD. And we need to assess whether people who are in treatment have ADHD or substance abuse or both. Impulsivity as a result of ADHD needs a different approach than that of just pure substance abuse. So impulsivity in ADHD involves blurting out answers before questions have been completed, having difficulty waiting their turn, and interrupting or intruding on others' conversations or personal space. Some symptoms that caused impairment need to be present before age 7 years of age. Impairment is present in 2 or more settings, which this helps us rule out anxiety disorders. If somebody does this primarily at school, for example, they may have an anxiety disorder that is centered around school, or this behavior may have been reinforced at school. But if they act this way at home and at school, or in 2 other settings, the chances are that it's something more inside the person than having to do with the environment. And the symptoms need to cause clinically significant impairment. That goes without saying. Now, we're starting to realize that a lot more adults haven't grown out of their childhood ADHD. Or maybe were never diagnosed in childhood. Adult symptoms of ADHD also include hyperactivity, poor concentration. It often presents as emotional lability. They can be very happy one moment, very angry another moment. They may have a hot temper, fly off the handle really easily. Inability to complete tasks and disorganization. Stress intolerance, and again, impulsivity. All of the characteristics that we described in children, but maybe tempered a little bit as the person has grown older. For example, they may sit still, but they may feel restless. Adjustment disorder is basically your run-of-the-mill garbage diagnosis that is slapped onto somebody if they don't neatly meet the criteria for any of the other more severe diagnoses. It involves behavioral or emotional symptoms which occur within 3 months of an identified stressor, and this can be moving, starting a new school, changing jobs, divorce, death, whatever. These behaviors are clinically significant, as evidenced by at least one of the following. After the exposure, the behavior or emotional symptoms seem in excess of what is normally expected, or significant social functioning or occupational impairment occurs. The disturbance does not meet the criteria for another specific Axis I disorder, such as generalized anxiety, major depressive disorder. The behavioral or emotional symptoms do not represent bereavement or grief. And once the events or stressors have terminated, the symptoms do not last more than an additional 6 months. So this is a relatively time-limited disturbance in functioning in reaction to a stressor. Now we're going to talk about mood disorders, and the first one we're going to start with is anxiety. Generalized anxiety is sort of a step up from adjustment disorder. It lasts for at least 6 months and produces excessive anxiety and worry about a variety of events and situations, not just how are my labs going to come back from my biopsy, or am I going to get fired from my job, but the job, the bills, the medical stuff, the children. There's a variety of things that the person worries about. There's a significant difficulty in controlling the anxiety and worry, and there's a presence for most days over the previous 6 months of 3 or more of the following symptoms: feeling wound up, tense, or restless, becoming easily fatigued or worn out. Now, if you're wound up, tense, and restless a lot, you're going to get easily fatigued and worn out. Concentration problems, irritability, significant muscle tension, and difficulty with sleep. Most of the time, the person has a difficulty falling asleep or staying asleep. But some people, their reaction is just to oversleep. They just want to block it all out. The symptoms are not part of another mental disorder. They cause clinically significant distress, and it's not due to a substance or medical issue. Now, substances, such as stimulants, can cause anxiety symptoms. Alcohol, while we generally think of it as a depressant, the first part of it is a depressant, and as the person sobers up, it produces an anxiety response. And a lot of people, when they start feeling that anxiety, as they start to sober up, they drink again in order to quell the anxiety. And it's a vicious cycle. So stimulants and alcohol are your two main offenders. Medical issues, including hyperthyroid and blood sugar issues, diabetes, hypoglycemia, can all lead to symptoms of anxiety, feeling tense, wound up, on edge. Some arrhythmias and heart conditions can also lead people to feel this way. So it's important that they have a medical workup to make sure that we rule out any physical causes of the anxiety symptoms. Panic disorder is present in people who typically have panic attacks in response to either a phobia or generalized anxiety. A panic attack is a discrete period of intense fear or discomfort in which 4 of the following develop abruptly and peak within 10 to 15 minutes. As we go through these, you'll see that a lot of them are very similar in symptoms to heart disease, heart attack, arrhythmias, and some other disorders, especially physical problems. So it's extremely important not to downplay these and just say, oh, Sally's just having a panic attack. If the person feels like they need to be evaluated by a doctor, make sure that happens. Palpitations, pounding heart, or accelerated heart rate. This can be a panic disorder, this can be a heart attack, or this can be stimulant intoxication. Sweating, trembling and shaking. Again, this can be stimulant intoxication, a panic disorder, or low blood sugar. Sensations of shortness of breath or smothering. This is a common symptom of a heart attack. This is also a common symptom of a panic attack. Feeling of choking, chest pain or discomfort. Nausea or abdominal distress. Feeling dizzy, unsteady, lightheaded, or faint. Again, this is something that can be either low blood sugar, a thyroid problem, stimulant intoxication, or a panic attack. So we don't want to just assume. Derealization, feelings of unreality or depersonalization, of being detached from oneself, being a fly on the wall, kind of being out of your body. Fear of losing control or going crazy. Fear of dying. Numbness or tingling sensations, especially in the face or extremities. and chills or hot flashes. Agoraphobia is something that often develops in concert with panic attacks. As people start to have panic attacks, they worry so much about having another panic attack and being in a situation in which they can't control it that eventually they start to fear leaving their own house. Agoraphobia is diagnosed when a person has recurrent, unexpected panic attacks. It's characterized by excessive fear or worry about having a panic attack in a public place, and at least one of the attacks has been followed by 1 month or more of persistent concern about having additional attacks, worry about the implications of the attack or its consequences, like losing control, having a heart attack, or what other people think about them, or a significant change in behavior related to the attacks. Another anxiety disorder is called obsessive compulsive disorder. Now there's obsessive compulsive anxiety disorder and there's also obsessive compulsive personality disorder. It's very important to differentiate the two. Obsessive compulsive anxiety disorder is defined as obsessions that are recurrent and persistent thoughts, impulses, or images that are experienced and caused marked anxiety or distress. The thoughts, impulses, or images are not simply excessive worries about real-life problems. For example, worrying that you're going to lose your job and then you're going to become homeless and you're going to be on the street. The person attempts to ignore, suppress, or neutralize the thoughts, impulses, or images with some other thought or action. So if their fear is about somebody breaking in and killing their family, they may check the doors 6, 7, 8, 9, 10 times before they go to bed. They may try to do something like counting or saying the ABCs or doing some other ritualistic action to try to quiet the noise from the anxiety. Compulsions are defined by repetitive behaviors the person feels driven to perform in response to an obsession. Now the first or most common thing we think of is people who hand wash. They constantly think about the germs on their hands and the germs that can get into their body, so they feel like they have to wash their hands all the time. The behaviors or mental acts are aimed at preventing or reducing distress or preventing some dreaded event or situation. Again, the hand washing, the person starts to have anxiety about the germs getting inside their body, making them sick and killing them. So they wash their hands repetitively. At some point during the course of the disorder, the person has recognized that the obsessions or compulsions are excessive or unreasonable. This doesn't apply to children. Children have what rationally we may think are irrational fears. The monsters under the bed or the boogeyman or whatever it is. These are things that we need to help them address developmentally, as they're probably more likely having difficulty moving into that developmental stage where they understand the difference between reality and fiction. The obsessions or compulsions cause marked distress, are time-consuming, generally they take more than an hour a day, or significantly interfere with the person's normal functioning. This is a judgment. This is something, if the person comes to you and says, it only takes me 10 minutes a day, but my wife and I argue about it all the time, or it's causing me to not be as productive at my job because I have to get up every 15 minutes and wash my hands, or whatever the issue is. If another Axis I disorder is present, the content of the obsessions or compulsions is not restricted to it. For example, preoccupation with food or weight gain in the presence of an eating disorder. The disturbance is not due to the direct physiological effects of a substance or a general medical condition. Generally, OCD is not difficult to diagnose from most of the other issues because of the ritualistic behavior, the preoccupation, and the need to try to neutralize the thoughts or images. It's a pretty concrete diagnosis. Phobias, we've all got them. Now, they may be not super problematic for us, but we all have little fears about things. Phobias, when they become clinically significant, start impairing a person's daily activities. For example, being afraid of spiders, and it prevents the person from being able to comfortably go outside or sit on the ground and have a picnic or whatever. Phobias cause marked and persistent fear that is excessive or unreasonable, which is cued by the presence or anticipation of a specific object or situation. Some common phobias are flying, heights, animals, receiving an injection, seeing blood. Exposure to the phobic stimulus almost invariably provokes an immediate anxiety response. The person recognizes that the fear is excessive or unreasonable, but has difficulty controlling that fear. Therefore, the phobic situation is avoided or endured with intense anxiety or distress. Avoidance, anxious anticipation, or distress in the feared situations causes significant impairment. In individuals under 18 years of age, the duration is at least 6 months. Now I'll give you an example. I have an unreasonable fear of heights. We went to Tennessee, and we were in the World's Fair globe thingy that's like 3 stories up. And when you walk, it shakes a little bit. My husband thought it was absolutely hilarious that I was pressed up against the center console of that thing like wallpaper. And I realized it wasn't going to fall, but it was this big ball, and you could actually see down kind of at foot level because it was transparent. Now, yes, I endured it with intense anxiety and distress. I realized it was completely irrational and unreasonable. Nevertheless, it still caused significant impairment, if you want to consider that impairment. I wasn't able to enjoy the experience, and my husband found it quite amusing. Differential diagnosis of phobias. We need to look at obsessive compulsive disorder. If the phobia does not cause a compulsion, if there's not a compulsion to match the obsession, it's probably a fear or a phobia. PTSD causes people to avoid stimuli associated with a severe stressor. For example, if somebody was in a high-rise building when it caught on fire, they may not want to go into high-rise buildings anymore. And that's more of a phobia that's related to PTSD. They're avoiding the stressor to avoid the reminders of what's going on. And in reality, when you look at it from their perspective, it's not that irrational and unreasonable. They don't want to be in that situation again. Separation anxiety disorder. This is often in children. Social phobia is the avoidance of social situations because of a fear of embarrassment. And panic disorder with agoraphobia generally starts out with a phobia or a fear or an anxiety that starts causing unexpected panic attacks, which lead the person to be afraid to leave their house. Now we'll move on to acute stress and PTSD. Acute stress disorder occurs immediately after a stressor in which there was intense horror, a sense of helplessness. PTSD kicks in later if the person doesn't adequately resolve their anxiety and symptoms associated with the event. In acute stress disorder, the person's been exposed to a traumatic event in which they experienced, witnessed, or were confronted with something that involved actual or threatened death or serious injury, or a threat to the physical integrity of themselves or others, If you watch somebody get killed, you're going to be impacted and traumatized, maybe not just as much as the person who got killed, but in a major way. Children who watch their parents in a domestically violent relationship where mom gets the crap beat out of her, their exposure to a traumatic event, they experience and witness something that involves serious injury to someone else, and it's someone who's a primary caregiver. So you can see where young children growing up in these relationships can develop symptoms of PTSD. The person's response involved intense fear, helplessness, or horror. Well, think about a 6-year-old watching dad beat the crap out of mom. Yeah, he's going to be afraid it's going to happen to him, feel helpless to help mom, and it's horrific to watch. Either while experiencing or after experiencing the distressing event, the individual has 3 or more of the following dissociative symptoms: a subjective sense of numbing, detachment, or absence of emotional responsiveness. They're in shock. Sometimes they feel like it was a dream. That couldn't possibly have happened. I must have been dreaming. A reduction in awareness of his or her surroundings. They feel like they're in a daze. Generally, they have what we call the million-mile stare. They're just kind of looking through you. Derealization, depersonalization. Feel like they're kind of out of their own body. And dissociative amnesia, which is the inability to recall important aspects of the trauma, like what were you doing right when it happened, or when the person broke into your house, what was the first thing that you did? Oh no, I can't remember. That's not resistance. That's the mind's way of protecting you from remembering some of this stuff because you're too vulnerable right now. The traumatic event is persistently re-experienced in at least one of the following ways: recurrent images, thoughts, dreams, flashbacks, or a sense of reliving the experience, or distress on exposure to reminders of the traumatic event. Now, distress on exposure to reminders of the traumatic event can be anniversaries, news reports, TV shows that vaguely resemble something that happened. There are a lot of different things that can remind people of a traumatic event. Avoidance of stimuli that arouse recollections of the trauma. Pretty self-explanatory. Marked symptoms of anxiety or increased arousal, such as difficulty sleeping, irritability, poor concentration, hypervigilance, always being on alert, and an exaggerated startle response. My uncle was in Vietnam, and to this very day, and it's 2010 right now, when you wake him up, you tap his feet and you duck because he wakes up swinging if he was in a deep sleep. This is an exaggerated startle response that he still has. The disturbance causes clinically significant distress. The disturbance lasts for a minimum of 2 days and a maximum of 4 weeks and occurs within 4 weeks of the traumatic event. Now remember at the beginning I said ASD occurs first, and if the stuff isn't resolved, then it can develop into PTSD. We'll talk about the onset of PTSD in the next couple of slides. And it's important to remember that the disturbance cannot be due to the direct physiological effects of a substance or a general medical condition, and is not better accounted for by brief psychotic disorder, or is not merely an exacerbation of a pre-existing Axis I or Axis II disorder. The PTSD has to involve a real experience. If it's a delusion or part of a psychotic episode, PTSD is probably not going to fit as an accurate diagnosis unless in the midst of a psychotic episode they got involved in something in which they were traumatized. PTSD, again, involves exposure to that traumatic event, It's persistently re-experienced, and part of the development or progression from ASD to PTSD is more powerful re-experiencing. Recurrent and intrusive distressing recollections, recurrent distressing dreams of the event, acting or feeling as if the event is reoccurring, intense psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the event. This is intense psychological distress. And physiological reactivity on exposure to internal or external cues. Internal cues can be this feeling of anxiety or dread that comes over people for, sometimes something completely unrelated that shocks them back into the trauma. Smells, sights, sounds, situations, anniversaries, all these things can trigger a remembering or reliving of the event. Persistent avoidance of stimuli associated with the trauma and numbing of general responsiveness, which was not present before the trauma. Now, numbing of responsiveness is a new symptom. This wasn't present in ASD. This numbing of responsiveness means the person's just kind of existing. They're not as able to experience joy or sadness or elation or excitement anymore. They're just kind of blah all the time. It's indicated by 3 or more of the following: efforts to avoid thoughts, feelings, or conversations associated with the trauma, to avoid activities, places, or people that arouse recollections of the trauma, inability to recall an important aspect of the trauma, markedly diminished interest or participation in significant activities. Okay, this is new again. So not only is the person just kind of walking around and blah and can't really experience and enjoy life anymore, but they also just really don't give a crap about much. We see these symptoms a lot in major depressive disorder. So when you're doing differential diagnosis, it's important to look and say, is this PTSD or is this depressive disorder? And the key factor is, was it brought on by a trauma or was it something else? A restricted range of affect. That goes with the general lack of responsiveness. And a sense of a foreshortened future. A person doesn't expect to have a career, marriage, children, or a normal lifespan. I did a lot of work with law enforcement and emergency service personnel, and believe that there is a certain type of PTSD that comes on over time. And a lot of cops, you see this develop as they start to become burned out, and they call it burnout, but much of it is PTSD. They'll wake up and they'll be in the middle of trying to, quote, catch a perpetrator, when in reality they're trying to choke out their spouse. Feeling of detachment or estrangement from others is not uncommon in law enforcement officers. So we look back at, what do they see every day? They see people at their worst, doing horrific things, and sometimes they are unable to stop it. So they have this sense of helplessness. Most law enforcement officers got into their jobs because they wanted to help people, and they needed to have that sense of control. When that's stripped away from them, it really rocks their world. And they compartmentalize. Most cops can't sit there. They don't have the luxury of feeling anxiety, stress, horror in the midst of what's going on. So they take it, they stuff it down, they lock it up in a box somewhere, and eventually all the energy required to keep all that stuff locked up just sucks all their energy out of the rest of their life. And we start to see the PTSD symptoms coming on. More symptoms include persistent symptoms of increased arousal, as indicated by difficulty falling or staying asleep, irritability and outbursts of anger, difficulty concentrating, hypervigilance, and that exaggerated startle response again. The duration of the disturbance must be more than 1 month. Remember, ASD was a maximum of 1 month. This has to be more than 1 month. And it causes clinically significant distress or impairment in one or more areas of functioning. There are a variety of anxiety disorders. It's important when you're looking at anxiety disorders to differentially diagnose them from substance use disorders, especially detoxification from alcohol, stimulant intoxication, medical disorders such as hyperthyroid, blood sugar disorders, and a variety of other less common medical issues. So it's important somebody has a physical workup. Anxiety can also be misdiagnosed as bipolar, hypomania, or as depression, because if a person's anxious for long enough, they get exhausted and they can't do it anymore. They can't stand it. They're anxious all the time and they just can't even face the world. So they start to feel very depressed, exhausted, have difficulty sleeping, changing in eating habits, loss of pleasure in most activities. If the cause of the depression is a generalized anxiety or an obsessive compulsive disorder, it's imperative to treat both of them and to acknowledge the anxiety that's draining the person's energy. Now we're going to move on to depression. A major depressive episode is characterized by 5 or more of the following, which have been present nearly every day during the same 2-week period. Now, major depressive disorder either remits or the person becomes suicidal. This is not anything to play with. Dysthymia, on the other hand, generally lasts for a lot longer, but is of less severe intensity. Depressed mood most of the day. Markedly diminished interest or pleasure in all or almost all activities. Significant changes in eating patterns and sleeping patterns. Agitation or retardation in movement nearly every day. Fatigue or loss of energy. Feelings of worthlessness or excessive or inappropriate guilt. Diminished ability to think or concentrate or indecisiveness. Or recurrent thoughts of death, not just fear of dying, which can be accompanied by recurrent suicidal ideation. The symptoms cannot meet the criteria for a mixed episode, which is one of your bipolar disorders. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and are not due to the direct physiological effects of a substance. Now, the things that most often cause depression are stimulant withdrawal, alcohol intoxication, opiate intoxication and or withdrawal, and inhalants. So any of your depressants and your benzodiazepines, your anti-anxiety medications, can make people feel depressed. A general medical condition such as hypothyroidism and blood sugar problems can also cause symptoms of depression. And finally, bereavement, such as after the loss of a loved one, but the symptoms must persist for longer than 2 months or are characterized by marked functional impairment, morbid preoccupation with worthlessness, suicidal ideation, psychotic symptoms, or psychomotor retardation. Bipolar disorder is a disorder in which the person experiences both manic and depressive type symptoms. The symptoms can alternate between being manic and being depressed, or can concur, where the person's depressed and manic and seem to not be able to make up their mind. And they may be present to a greater or lesser degree. There's hypomania, which is not quite a manic state, and dysthymia, like I talked about before, which is not quite a major depressive disorder. With mania, there's a distinct period of abnormally and persistently elevated, expansive, or irritable mood lasting at least a week. During this period, 3 or more of the following have persisted to a significant degree. Inflated self-esteem or grandiosity. Now we want to differentially diagnose. This has to be a change. You don't want to diagnose this necessarily in a person with narcissistic personality disorder. During the manic episode, the person feels like they're all that, a bag of chips and a soda. A decreased need for sleep. They may feel rested after only 3 hours of sleep. Differential diagnosis, you want to make sure that the person's not using a stimulant such as cocaine, crack, methamphetamine, which makes them not need sleep. They're more talkative than usual, or they seem to have a pressure to keep talking. Again, this is a symptom of stimulant intoxication, in addition to mania or hypomania. A flight of ideas or subjective experience that thoughts are racing. Just things keep going through their head and they have to keep talking and all this stuff is going on. Distractibility. Their attention is too easily drawn to unimportant or irrelevant external stimuli. Now you remember at the beginning of the presentation I talked about how oftentimes, especially adult ADHD, is misdiagnosed for bipolar. Now you're looking at the symptoms of a manic episode, and what are you seeing? Distractibility. That is a symptom of adult ADHD. A flight of ideas, inability to focus, can also be a symptom of adult ADHD. In mania, though, there may be an increase in goal-directed activity, either socially or at work or school or sexually. The person tends to get something in their mind and they are going to do it, and they're going to do it to the nth degree. An excessive involvement in pleasurable activities that have a high potential for negative consequences. They're looking for the rush. The symptoms do not meet the criteria for a mixed episode, and the disturbance caused marked impairment in functioning. With adult ADHD, the symptoms are persistent for a long period of time. In a manic episode, the symptoms, the person's presentation changes during the episode. The symptoms last at least a week, sometimes more, but not for months and months and months. So if you're talking to the person and they say, I've always been this way, I've always been easily distracted, or I've always been impulsive, then we're going to start looking back at some other diagnoses besides a manic episode. Hypomania is diagnosed when the manic episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization, and there are no psychotic features. So a hypomanic episode in some people may just present as a marked increase in goal-directed activity. They are on. In a mixed episode, the criteria are met for both manic and major depressive episode nearly every day during at least a 1-week period. Bipolar I involves the person having episodes of major depression and full-blown mania. Bipolar II involves episodes of the person having major depression and hypomania. Additionally, in Bipolar II, there is no history of manic or mixed episodes. I think we see Bipolar II a whole lot more than we probably give credit for. People don't like their hypomanic symptoms to go away because that's when they finally feel good after they've been depressed for a really, really long time. And hypomania doesn't tend to cause clinically significant impairment. For some people, that's when they feel that they're the most productive. So they don't complain about the hypomania. It's the major depressive symptoms that they complain about. Now, in many cases, the treatment's going to be very similar, but some of the medications that are appropriate for major depressive disorder may trigger a manic or hypomanic episode in persons with bipolar II disorder. Cyclothymic disorder. For at least 2 years, there have been a presence of numerous episodes of hypomanic symptoms and numerous periods of depressive symptoms that do not meet the criteria for major depressive episode. So they've been hypomanic and dysthymic. During the above 2-year period, the person's not been without symptoms for more than 2 months. The symptoms in criterion A are not better accounted for by schizoaffective disorder, are not superimposed on schizophrenia or schizophreniform disorder, delusional disorder, or psychotic disorder, NOS. In my almost 15 years of practice, I can't say that I remember ever seeing someone who has been diagnosed as cyclothymic, either by myself or by the psychiatrist that I work with. I don't think this is extraordinarily common, but I think it's important to be aware when you're diagnosing, because the medication regimes, and this is generally the biggest issue, the medication regimes may be different for someone who has cyclothymic disorder. Medical disorders can cause depressive-like symptoms. Diabetes, hypothyroid, fibromyalgia, and chronic fatigue syndrome can all cause depressive-like symptoms. Likewise, hyperthyroid can cause manic-like symptoms. Additionally, certain substances can cause depressive and manic-like symptoms. Opiates, anti-anxiety medications, benzodiazepines, depressants, barbiturates, inhalants, and GHB can all cause depressive-like symptoms. Ecstasy, MDMA, methamphetamine, cocaine, steroids can all cause manic-like symptoms. It's important to rule out through just a simple urine screen the presence of any substances that may be confounding your diagnosis. In summary, there are a variety of depressive and bipolar disorders. Depression, dysthymia, which is a less intense version of depression, mania, hypomania, which is a less intense version of mania, bipolar I, which is characterized by episodes of major depressive disorder and mania, and bipolar II, which is characterized by episodes of major depressive disorder and hypomania. Cyclothymia, which is diagnosed as someone who has episodes of major depressive disorder and mania or hypomania at the same time. And it's important to differentially diagnose between actual mood disorders, substance-induced mood disorders, and mood disorders caused by a general medical condition. Now we move on to your addictive disorders. Substance abuse is a pattern of substance use that leads to clinically significant impairment in one or more of the following ways. Failure to fulfill major role obligations at work, school, or home. Continued use in spite of physical hazards, such as driving under the influence. Legal problems as a result of use. This can include criminal legal charges or civil legal charges, such as bankruptcy, and interpersonal or social problems. Substance dependence, on the other hand, is a more intense problem than substance abuse and is characterized by a maladaptive pattern of substance use or abuse, leading to clinically significant impairment or distress as manifested by 3 or more of the following, occurring at any time in the same 12-month period. 12 months is a long time. Tolerance, as defined by either needing markedly increased amounts of the substance or diminished effect with continued use of the same amount of the substance. So you need more to get the same high, or you're using the same amount and you're not feeling the same effects. Withdrawal, as manifested by either having to use the same or a closely related substance to avoid withdrawal symptoms, or taking the substance in larger amounts or over a longer period of time than intended to avoid the withdrawal symptoms. There can also be psychological withdrawal, in which the person has obsessions or preoccupations with the substance when they're not using it. There's a persistent desire or unsuccessful effort to cut down or control substance use. A great deal of time is spent in activities necessary to either get the substance, use the substance, or recover from the effects of using the substance. Important social, occupational, or recreational activities are given up or reduced because of use. And the substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or made worse by use of the substance. I've listed the characteristics for intoxication and withdrawal of your most common categories of substances. You can find out more about these by clicking on the link at the bottom of this slide. Eating disorders are characterized by a preoccupation with or fear of weight gain, preoccupation with body image, and either a preoccupation or fear of food as a result of the fear of weight gain and distorted body image. Anorexia nervosa is defined as someone who has less than 85% of their expected body weight, an intense fear of gaining weight, they place undue emphasis on body shape or weight, and they haven't had a period, amenorrhea, for at least 3 consecutive months. Bulimia is characterized by recurrent binge eating at least 2 times per week for 3 months, and recurrent inappropriate compulsive behaviors to prevent weight gain, such as self-induced vomiting, abuse of laxatives, diuretics or other medications, or excessive exercise. Similar to anorexia, there's a persistent over-concern with body shape and or weight, but there is not the same characteristics of anorexia of the less than 85% of expected weight. People with binge eating disorder also have the recurrent episodes of binge eating, which is characterized by eating larger amounts of food than normal during a short period of time, specifically within any 2-hour period, a lack of control over eating during binge episodes. And binge eating episodes are associated with 3 or more of the following: eating until uncomfortably full, eating large amounts of food when not physically hungry, eating much more rapidly than normal, eating alone because you're embarrassed about how much you're eating, or feeling disgusted, depressed, or guilty after overeating. Marked distress regarding binge eating is present, and it occurs on average at least 2 days a week for 6 months. The binge eating is not associated with the regular use of inappropriate compensatory behavior, such as purging or excessive exercise, and does not occur exclusively during the course of bulimia nervosa or anorexia nervosa. Finally, gambling addiction is characterized by the American Psychological Association by having a preoccupation with gambling, a tolerance or a need to gamble with increased amounts of money in order to achieve the desired excitement, withdrawal or a sense of being restless or irritable when unable to gamble or when attempting to cut down or stop gambling, using gambling as a means of escape from problems or or relieving a dysphoric mood. Other symptoms of gambling include chasing, such as after losing money gambling, the person returns another day in order to get even. The big one's in the next hand. It's just around the corner. Lying to family members, therapists, or others to conceal the extent of involvement with gambling. Committing illegal acts in order to finance gambling. Risking significant relationships because of the gambling. Relying on others to provide money to relieve a desperate financial situation caused by gambling. And a loss of control, making repeated unsuccessful efforts to control, cut back, or stop gambling. When we talk about addictions, we have to differentiate between abuse and dependence. Dependence is characterized by having that tolerance, physical and or psychological, and it's a much more severe impact than substance abuse. It's important to be able to identify general symptoms of intoxication for alcohol, marijuana, depressants as a category, and stimulants as a category. Eating disorders are extremely prevalent in our culture. Therefore, it is important to be able to help people identify when they have substituted one addiction, such as they stopped drinking but now they are binge eating. Eating disorders involve a similar use of a substance in order to escape from emotional pain or distress. Additionally, gambling and other behavioral addictions such as work, shopping, or sex can be used as substitute addictions instead of actually helping the person get clean and sober. It's important to note that people also may have multiple addictions going on. When they can't get one, they may use the other. So any behavior, activity, substance that they use maladaptively should really be looked at carefully to see if they are using it in a manner that qualifies as an addiction. Developmental disorders. We're going to skip down to Axis 3, physical issues. Axis 2 represents your developmental and your personality disorders. Since those are very difficult to diagnose in early recovery, it's best to put a provisional diagnosis if you suspect there may be, for example, borderline tendencies, as opposed to giving someone a diagnosis of a borderline personality disorder. The reason for this is because many Axis 2 diagnoses will preclude people from treatment in certain institutions. Back to Axis 3, physical issues. Physical conditions can mimic intoxication or withdrawal and can worsen during use or withdrawal. For example, blood pressure problems. People's blood pressure often skyrockets when they're detoxing from alcohol. If they've already got hypertension, then they may be at risk of a stroke when they're detoxing. People often use to self-medicate physical and emotional conditions. So it's important to ask them the reasons they started using. They may have had a surgery and started using opiates. And a real nice side effect of the opiates, not only did it take away the physical pain, but it made them not give a crap about anything. So when the going got tough, even after their physical pain was gone, they may return to the opiates just to get that feeling of not caring again. Effective treatment involves addressing physical and emotional conditions and treatment side effects, which are unpleasant. Side effects can be side effects of medication, can be just generally the dysphoria during early recovery. In order to help people stay clean and sober and develop a sense of health, help, and hope, we need to make sure that we can help them deal with the unpleasant side effects. We're going to go through a few medical issues, and in each slide I've identified one medical issue, and I've highlighted or bolded the characteristics of that medical issue that is also similar to the characteristics of anxiety and or depression. I've done this in order to sort of illustrate how easy it is to miss a physical diagnosis when there's a psychological diagnosis, and vice versa. Chronic fatigue syndrome has a whole list, a whole litany of symptoms that are associated with it. But similar to anxiety and depression, a person with chronic fatigue syndrome experiences fatigue, difficulty with concentration, sleep problems, headaches, exhaustion, chest pains, bloating, diarrhea, jaw pain from clenching their teeth, possibly at night, or just jaw pain, depression, anxiety, irritability, and panic, being short of breath, and weight changes. All of those symptoms are also common to depression or anxiety in addition to chronic fatigue syndrome. People can have both, or they might have one or the other, but it's important to figure out what you're dealing with. In diabetes, there are fewer symptoms that overlap, but the symptoms of unusual weight loss and extreme fatigue and irritability can be related or misdiagnosed as depression or anxiety when in actuality there's a diabetic condition underlying it. When people are diagnosed with diabetes, though, it's important to remember that many people go through a grieving process because diabetes is misunderstood in many cases, and many people take that as sort of a death sentence of sorts. It means they can't eat the same way. They may have to give themselves insulin injections. Their body is not, quote, normal. So there's a grieving process to go through. And that can compound any mental health issues that may already be pre-existing. People who are hypoglycemic, when their blood sugar gets too low, can get nervous. They may sweat, intense hunger, trembling, weakness, palpitations. These are all symptoms of anxiety or panic disorders. So again, we need to figure out, are your panic attacks, if we're calling them panic attacks, are they really panic attacks, or do you have low blood sugar, or both? When you have low blood sugar, does it create a situation that sets you up to have a panic attack? If so, there are probably some easy fixes here. Fibromyalgia is a very painful condition that is characterized by, again, a litany of symptoms, but some that are common to depression or anxiety include fatigue, decreased energy, changes in sleeping, difficulty remembering, concentrating, and performing simple tasks, tension or migraine headaches, jaw and facial tenderness, feeling anxious or depressed, numbness or tingling in the face, arms, hands, legs, or feet. This is really common in panic attacks, and dizziness. Many of these are common symptoms in people with high anxiety or panic attacks, but also to a certain extent with depression. We need to make sure that we're addressing both of them. If a person with fibromyalgia also has an anxiety disorder, the muscle tension caused by the anxiety is going to exacerbate the fibromyalgia. Hypertension. Similar to a panic attack, people may have chest pain, difficulty breathing, heart palpitations, pounding in their chest, neck, or ears, fatigue, and confusion. We don't want to mistake hypertension for a panic attack and just say, oh, well, she's just having a panic attack, or she just has an anxiety disorder. We need to make sure to get blood pressure measurements to rule out something that's more nefarious. Arrhythmias are characterized by a pounding in your chest, dizziness or feeling lightheaded,
shortness of breath, chest discomfort, and weakness or fatigue. These are the very same symptoms that characterize a panic attack. So again, it's imperative that we differentially diagnose and have a doctor differentially diagnose a panic attack from a heart attack or an arrhythmia. We do not want to downplay something as a panic attack if it's not. Sometimes the consumers can't tell the difference. Better to be safe than sorry. Heart disease. Again, shortness of breath, palpitations, fast heartbeat, weakness or dizziness, nausea, and sweating. All characteristics of a panic attack. Make sure that the consumer is not abusing stimulants, is checked for physical issues such as heart disease, and look and see if the person has a history of anxiety disorders and or maybe they drink too much caffeine or have too high of an intake of other stimulants. These are all things that are identifiable and workable. Not necessarily easily, but identifiable and workable. Lupus has painful swollen joints. People have sensitivity to the sun, which can cause them to stay indoors more often, which may lead to some symptoms of depression. Extreme fatigue, confusion, dizziness, and depression. Lupus is pretty straightforward in its diagnosis. We do need to, however, make sure that we don't underestimate the impact that a diagnosis of lupus will have on somebody's mental and emotional state. Polycystic ovarian syndrome is characterized by infrequent, absent, or irregular menstrual periods, increased facial hair on the chest, torso, thumbs, or toes, cysts on the ovaries, oily skin, dandruff, weight gain or obesity, baldness in women, patches of skin on the neck, arms, breasts, or thighs that are thick and dark brown or black, skin tags, pelvic pain, anxiety or depression, and sleep apnea. One of the most pronounced symptoms of polycystic ovarian syndrome that people often report is the depression. The cysts on the ovaries tend to wreak havoc with the hormones, which cause a whole range of other symptoms. Additionally, the additional weight gain and seeming impossibility of losing weight and losing hair in 30-year-old, 40-year-old women often tends to cause a reasonable amount of depression and anxiety. So helping them deal with those issues as well as get themselves stabilized physically is important to working with someone with polycystic ovarian syndrome. Thyroid problems can be one of two spectrums: hyper, which means their thyroid is operating in overdrive, or hypothyroid, meaning it's not working fast enough. Hyperthyroid tends to produce symptoms that are very similar to a panic attack and sometimes hypomanic episodes. The person is really high-strung, nervousness, insomnia, breathlessness, trembling hands, muscle weakness. People with hypothyroid tend to be more depressed. They experience fatigue, weight gain, weakness, constipation, irritability, and decreased libido. In summary, Axis 3 represents your medical issues which have symptoms that can mimic substance abuse or mood disorders. It's important to remember that side effects of many medications can also mimic substance abuse or mental health disorders. So people need to be educated about the side effects and provided with alternatives or methods to combat the side effects of some medication if we expect them to stay med compliant. Some people will self-medicate physical and or emotional issues with substances. Therefore, again, it's important to give a provisional diagnosis of a mental health illness if someone is still using substances, because you don't know exactly what's underlying. Sometimes they have a history of depression or anxiety, so that makes it easy. But if they don't have a history prior to their substance use, it's better to give a provisional diagnosis than to put down that somebody has recurrent major depression or bipolar disorder before you've completely ruled out substance withdrawal.
All right, so now we've talked about how anxiety and depression can sort of feed off one another or impact one another. We've also talked about how medical disorders can either mimic or exacerbate mental health conditions and anxiety conditions, and how substance abuse and mental health conditions can also make physical issues worse. We're also going to move on to psychosocial now. And psychosocial is sort of a catch-all category that encompasses everything from legal, social supports, environment, housing, food. And we want to talk about making sure that people have these needs met. Now, Abraham Maslow proposed the hierarchy of needs way back when, and it still holds very true now. The first level, or the foundation that we talk about, is making sure that people get their basic needs of breathing, food, water, sleep, and physical health met. A homeless, hungry, sick person is really not going to care very much about working on their depression. So we need to make sure that they have their basic needs met first. Next comes safety. Now, safety is kind of interesting because we talk about safety, the first thing we think of is physical safety. And while that's a huge part of it, people have to feel physically safe in order to get adequate rest and not be on edge and not be exhausted all the time. They also have to have emotional safety. They have to feel like they are going to be respected. With that comes our issues with cognitive distortions. People actually need sort of to create safety from themselves, in a way, if you want to think of it like that, in changing their thought patterns. Their negative, self-defeating thought patterns are very harmful and toxic to themselves. So they need to change those before they can really move on to being able to focus on other people and creating fulfilling relationships. We know that negative attracts negative and generally repels positive when we're talking about relationships. So if you have somebody who's just full of all these toxic negative thoughts, they're really not probably going to attract a good, sober social support system. So in the safety category is where we start addressing cognitive distortions, thinking errors, and self-destructive behaviors. Other things that you need to consider in the psychosocial domain, in addition to making sure that people have supports, is making sure they have the financial resources to keep their lights on and to have an environment that can be safe. Childcare, if necessary. Employment can fall into the psychosocial aspect. Are they employed? Are they bringing in a paycheck? Do they have some purposeful action, if it's not employment, volunteer work, something to help them stay busy and connected? Legal issues also fall in here. Just about anything that involves the person interacting with the environment can fall into the psychosocial aspect. In many treatment centers, we refer to Axis 4 issues or psychosocial issues as wraparound services. These are the services that we provide in order to get people to the point where they're ready to actually work on their mental health or substance abuse issues. Physiologically, food and nutrition. We know that if they're hungry, their blood sugar's low, it's probably going to impact their mood. Some people become depressed, some people become anxious, some people become downright nasty. We need to make sure they have adequate nutrition in order for their body to build the serotonin and the other neurochemicals that help them feel happy and stabilize their moods. We also need to make sure that they have good food and nutrition in order to keep their immune system up, because when we get sick, we tend to not handle stress as well. We tend to become more depressed, sometimes more anxious, more irritable. We want to do everything we can to prevent people from becoming sick and tired. Safety is housing, We need to make sure that they have financial resources to have adequate housing. We need to make sure that in this physiological area they can also access medical services. They need to be safe, again, from themselves. People who need psychotropic medications, while this is not necessarily, you could say, a biological need, they probably won't die if they don't have an antidepressant. In order to create that environment where they can have positive thoughts and feel happy and feel safe, they may need to have access to medications and psychotropic medications. And transportation. If they can't get to their treatment, they can't participate in treatment. If they can't get to their doctor's appointment or get to the grocery store, then they can't get some of those other things that they need for their basic foundation needs. And then love and belonging. Now, we would all love to say that people come in and they've got a wonderful support system that's there to help them through the recovery process, but a lot of times that's just not so. By the time they actually come to treatment, they've alienated a lot of people. They've worn a lot of people out. Their social supports may still be concerned, but they may not have a whole lot of energy left to give. So again, we need to help people start to learn to stand on their own 2 feet, change their thought patterns, and do things to nurture relationships instead of just sucking them dry. Finally, Axis 5 is the GAF, or the Global Assessment of Functioning. And I go through on here the different levels of the GAF. Generally, 91 to 100, these are people who are doing just ducky, and they're not going to be in to see you. 81 to 90 are people experiencing minimal symptoms. Generally, again, they're not coming in to see you unless they just have a lot of extra money hanging around. You don't generally see people present for treatment until they're down in the 60 level. 61 to 69, they've got some mild symptoms. Some people may start presenting for treatment at this point. 51 to 60 is moderate symptoms. These people are probably presenting. This is where you generally see most of your people. Once you start to get below 50 or at 50, you're starting to talk about residential treatment. These are people who may need to be monitored in order to prevent them from harming themselves or others. Now, the GAF is just a general rule that we can use in order to try to measure progress in treatment. It's very sort of loosey-goosey depending on how people define their symptoms and what is meaningful for them in recovery. The one thing about the GAF is that it is often necessary for reimbursement and for a lot of our state outcome measures. So it's important to be aware of what the GAF is. For example, in Florida, Medicaid will not reimburse for residential treatment if somebody has a GAF of, say, 70. So you need to be aware of what the parameters are for the reimbursement units that you're working with. In summary, it's important to remember that psychosocial issues reflect how the person exists and interfaces with the environment. As things become difficult in those lower areas of the pyramid, the safety and physiological, people will become increasingly agitated, depressed, angry, generally having some dysfunction going on, which will impact their mood. Their mood will then impact their interaction with the environment, and it's a negative circle. So anywhere that you can intervene, whatever they're willing to work on to start trying to create a situation in which they can be happy and healthy, is a good place to start, because anything you do positive is going to have positive effects. In order to focus on mental health issues, basic physical and safety issues must first be met. There are some things that are ongoing. If you're working with somebody with HIV, you're not going to cure the HIV, but you do need to make sure that they are tending to their physical health needs so they're not feeling sick and exhausted and drained and achy and whatever else all the time. The GAF, as I said, is often used to assess appropriate placement level. And a GAF of 50 or below usually indicates a need for residential, maybe short-term, but residential treatment. Here are some additional brief texts that might be useful to you when trying to learn about co-occurring disorders, addiction, and mental health treatment. The Spanish version of some of the texts are also available, and I've listed them here.